بسم الله الرحمن الرحيم. I'm Dr. Ahmad Abdulrazak, Associate Professor of HPB and Transplant at Insurance University. We'll talk today about technical aspect of pancreatic. Pancreatic surgery is very challenging because of the anatomical criteria of the pancreas. So the pancreas is a retroperitoneal organ which lies behind most of the abdominal viscera and lies just on the aorta and the IVC. And the pancreas here we see it in this picture, and this is the liver, and this is a gallbladder. This is a common bile duct, and this is the stomach. C-shape is the duodenum, and the pancreas lie behind the stomach. And we see here the onset process and the portal vein and sphenomesenteric artery and vein pass through part of the parenchyma of the pancreas between the onset process posteriorly and the neck of the pancreas anteriorly. Also, this picture shows the different parts of the pancreas, which is divided into head, neck, body, and tail. The tail is in close contact with the spleen, and the head is in close contact with the C-shape of the duodenum. The artery and sphenomesenteric artery and sphenomesenteric vein pass through the parenchyma between the onset process and the neck of the pancreas. And this lower picture here shows the pancreas from behind. We see here the portal vein, sphenomesenteric vein, splenic vein, common bile duct, and onset process body and tail from behind. The CBD anatomy is very important for any surgeon who want to do any pancreatic biliary surgery. So the CBD pass behind the pancreas, and then at the end it goes through the parenchyma of the pancreas to join the pancreatic duct and open in the second part of the duodenum, the middle of it, what's called the ampulla of water. So after the cystic duct come out from the gallbladder, it joins the common hepatic duct to make the common bile duct. Another anatomical criteria which is close to the pancreas is the hepatic artery. So and the celiac trunk. The celiac trunk comes from the aorta at the level of T12. And the celiac trunk divided into three main branches: left gastric, here splenic, and the common hepatic artery. After the common hepatic artery come out from the celiac, it's the transverse part. It gives the gastroduodenal, and after that it changes direction to make the vertical part of the common of the hepatic artery. So if you want to identify the gastroduodenal artery, you just need to get the vertical part and transverse part of the common hepatic artery, and the one which is coming out is the gastroduodenal artery. After giving the gastroduodenal artery, the hepatic artery continue as a hepatic artery proper and divide at the hilum of the liver into right and left hepatic arteries. The pancreas gets its blood supply from the celiac trunk, mainly through the gastroduodenal, which gives the superior pancreaticoduodenal artery, and from the splenic artery, which comes from the celiac, and from the superior mesenteric artery, so the inferior pancreaticoduodenal artery. So the inferior pancreaticoduodenal artery make an anastomosis with the superior pancreaticoduodenal artery. This picture shows a cut section of the pancreas, which shows artery and vessels related to the head of the pancreas, the pancreaticoduodenal artery, and the superior mesenteric artery and the vein, which are in close contact with the pancreas between the neck of the pancreas and the onset process. Hepatic artery anatomy is very important to know the hepatic artery anatomy and the variation of the hepatic artery anatomy, because normal hepatic artery variation is very common. The hepatic artery, as we said, coming from the splenic and gives the GDA. After that, it divides into anterior and posterior at the hepatic hilum. In picture B, we see here that the hepatic artery proper gives only the right hepatic artery, and the left hepatic artery comes from the left gastric. In picture number C, we see that the hepatic artery mainly supplying the left, and this is and the right loop gets its blood supply from the superior mesenteric artery, and this is the replaced right hepatic artery. The replaced right hepatic artery is coming from the superior mesenteric, and it can be injured during dissection during Whipple procedure. In picture number D here, we see that the main hepatic, the left hepatic coming from the left gastric, and there is no main hepatic artery, and the right hepatic coming from the superior mesenteric. This is also completely replaced the right hepatic, but there is no main hepatic artery, and the left hepatic is supplied from the left gastric. Number E, this which is the most serious and can be injured very, and the injury for this case for the hepatic artery carry very bad prognosis, because its main hepatic artery is completely replaced from the superior mesenteric artery, and which gives the right and left hepatic arteries, and there is nothing, no blood supply coming from the left gastric. So this hepatic artery anatomy variation is very important for all surgeons who will go for procedure. As regards the venous drainage of the pancreas, so it is mainly through the portal vein and superior mesenteric vein. So splenic vein take direct branches from the body and neck of the pancreas, and for the head is coming through the anterior and posterior pancreatico-duodenal veins, which sometimes called epiploic veins, which drain directly to the superior mesenteric vein and portal vein, and these branches has to be tied off and secured properly during pancreatico-duodenectomy. So we talk about the anatomy of the pancreas. Now we will talk about the pancreatic surgeries. So there are two main categories for pancreatic surgeries. One is surgery for the inflammation, and second is the category and surgery for pancreatic tumors. For inflammatory process is either acute pancreatitis or chronic pancreatitis, and for surgery is either pancreatic head tumors or body and tail tumors. So for acute pancreatitis, surgery is not the main treatment of choice. Main treatment of choice is conservative management. So surgery is not common nowadays because of the very good action of the interventional radiologists who they can drain most of collections in the abdomen, and is only indicated in infected pancreatic necrosis, not responsive for antibiotics, with failure to drain by interventional radiology. So surgery for acute pancreatitis is mainly to drain abscess or infected pancreatic necrosis, which failed to be drained by ultrasound or CT. To diagnose infected pancreatic necrosis, we need two criteria. First, it's antibiotic dependent, so the patient does not improve without antibiotics, and second, the need for active intervention. And the presence of infection can be diagnosed by CT only where we can see gas in the pancreatic or peripancreatic tissues, or by ultrasound or CT guided aspiration and the culture, which shows either bacteria or fungus. Infected pancreatic necrosis can be diagnosed first by you have to diagnose first the necrosis, which is in the CT there is absence of enhancement of the pancreatic parenchyma, and infection, as we said before, you can diagnose it with gas either in the pancreatic or peripancreatic tissue, or after that by culture or by ultrasound or CT guided aspiration. And at the end it will end to multi-organ system failure, pulmonary edema, renal impairment, and anesthesia. In this case, we see infected pancreatic necrosis, and there is multiple air loculi. And there is a severity index, which is by CT scan, and there is modified also severity index. And for this index, we need to get or to know the prognosis of the patient who is infected pancreatic necrosis. If the score is from 0 to 3, the morbidity is 8%, and the mortality is only 3%. And if the score from 4 to 6, the morbidity is 35%, and the mortality is 6%. And then for severe cases from 7 to 10, by score, the morbidity is 92%, and the mortality is very high, is 17%. So for intervention, it is indicated in infected pancreatic necrosis or symptomatic steroid necrosis. So in symptomatic steroid necrosis, so there is no infection, but the patient had severe complication like gastric outlet obstruction or sinus or biliary obstruction with mass effect more than 4 weeks, and persistent symptoms like persistent pain and unwellness for more than 8 weeks. So these are the indications for intervention in acute pancreatitis. Usually the time of intervention after 4 weeks from the onset of the disease. Why 4 weeks? So after 4 weeks, the necrotic process has stopped extending. Usually there is clear demarcation between the viable and non-viable tissues, and after that infected pancreatic tissue has become walled off. And this approach will decrease the risk of bleeding and avoid removal of normal pancreatic tissue, because usually there is a demarcation between normal pancreatic tissue and infected pancreatic tissue. The type of intervention depends on what's called step-up approach, and we'll talk about it. First, we start by radiological method, CT ultrasound guided. Second is endoscopic, either by gastroscope. And the last is a surgical, which is either open or laparoscopy. For surgical techniques, you need to remove all necrotic and infected tissue and fluids, then preserve the vital tissue, avoid hemorrhage, and all fluid collection in the abdomen has to be identified and drained. So you have to map first by CT scan where is the collection and how to drain it. For open surgical necrosectomy, you can use either midline or bilateral subcostal. Body anterior of the pancreas should be exposed by entering the lesser sac. Great care is required that inflammatory adhesion may exist between the pancreas and stomach or transverse meso. Technical pairs in pancreatic necrosectomy, you have to know this slide very well. The bridement is performed bluntly. Avoid sharp dissection just by blind finger dissection, usually by digital, as we said, finger dissection, and careful use of an instrument and lavage. Avoid any sharp dissection. Only loose adherent tissue should be removed. Any strand you see making like a bridge between tissues, you have to be very careful because it can be a blood vessel, and if you just tear it, you will get in trouble with severe hemorrhage. So blunt finger dissection, just very loosely adherent tissues has to be removed, and after that avoid any vascular injury by very careful dealing with the blood vessels, and extensive irrigation of the necrotic cavity and drainage. Hydrogen peroxide may be used. Systematic approach in examining internal retroperitoneum behind transverse and ascending colon should be done. Don't leave any collection undrained. If massive bleeding, do packing. If colon vibrated outfall, perform ileostomy, and feeding tracheostomy can be. Step-up approach, as I said, is first to start by endoscopic and percutaneous drainage, and if failed, you can do surgical drainage either by minimally invasive or open necrosectomy. Now we finished the surgery and tricks for acute pancreatitis. Now we'll go for chronic pancreatitis. What are the indications to operate in patients with chronic pancreatitis? So chronic pancreatitis also is a medical disease, usually treated by medical treatment by gastroenterologist, by replacement of the pancreatic enzymes, treatment of diabetes by insulin, and pain by pain management doctors. But you need to think about surgical intervention in case of intractable pain or any other complications like biliary obstruction, pancreatic duct obstruction, duodenal obstruction, splenic vein thrombosis, which cause left side portal hypertension, also it's called left sectoral portal hypertension, chronic obstruction, pseudocyst, or any doubt of pancreatic carcinoma. So in this algorithm, we will see the algorithm for dealing with chronic pancreatitis. So, if there is a pain with chronic pancreatitis and severe intractable pain, you need to do high resolution CT scan. If there is any question about malignancy, you go for ERCP and EOS and biopsy, which will be the gold standard to differentiate between just chronic pancreatitis or there is associated pancreatic malignancy. If there is associated pancreatic malignancy, you go for pancreaticoduodenectomy or distal pancreatectomy according to the site of the mass. If there is no mass and just only fibrosis and scarring of the chronic pancreatitis, you need to take the decision according to the pancreatic duct. If the pancreatic duct is dilated, you can go for longitudinal pancreaticogenoscopy. If it is just focal dilatation of focal area from the distal pancreas, you go for distal pancreatectomy. If it is normal pancreatic duct, you go for pancreaticoduodenectomy with local head resection and first is the Pisto or modified Pisto, which is longitudinal pancreaticogenoscopy. In this case, you expose the pancreas or identify the pancreatic duct, which should be dilated by ultrasound. You open the pancreatic duct longitudinally, and after that, you do pancreaticogenoscopy with a roll loop. It's make pain relief in about 85% of the cases, does not endocrine function, which is very important, but the recurrence rate is high, it's 40-50% within 5 years. Another surgical procedure for chronic pancreatitis is the pancreaticoduodenectomy. In pancreaticoduodenectomy, the pancreatic duct is not dilated and the head contains a lot of calcified and cystic changes. It causes pain relief in about 85-90% and more endocrine insufficiency than the previous modified Pisto. Another surgery which is based on combination between resection and drainage procedure, which is a Frey procedure. In this picture, we see the Frey procedure. We remove most of the pancreatic head, leave part of the posterior pancreatic tissue, and after that, you put a pancreaticogenoscopy, which is a combination between resection and drainage procedure, and this is called the Frey procedure. Baker introduced duodenum preserved pancreatic head resection. In this case, we remove most of the pancreatic head by cutting it through the pancreatic neck and remove most of it, release all the adhesions, and after that you keep the C shape of the duodenum and you keep rim of pancreatic tissue and you do pancreaticogenoscopy here on the end to end, and after that into side, which is called Baker procedure. Another treatment for chronic pancreatitis is total pancreatectomy and auto islet transplant. Total pancreatectomy or islet transplant, you remove all the pancreas, you put in centrifuge, you take only the pancreatic endocrine tissue, and after that you transplant it in the portal vein to settle in the liver and secrete the insulin. It's not very effective, but is used in hereditary syndromes and small duct disease. It's causes pain relief in about 75% of patients, with 60-70 achieving narcotic independence. So we finished now the surgery for pancreatic inflammatory diseases, and now we'll go for pancreatic and periembolic tumors. This picture is a representation of the pancreatic anatomy. We'll see here the common bile duct, which goes through the pancreatic head and join the pancreatic duct to open the second part of the duodenum in the dilated area, which is called the ampulla of Vater. And we see here there is a mass in the head of the pancreas, and these are the lymph nodes around splenic artery, lymph nodes around the hepatic artery, and lymph nodes around the spermomesenteric artery and vein, which need to be resected with the pancreaticectomy. And this is another area of neoplasm in the tail of the pancreas. So, in pancreatic carcinoma, it can happen in the head, which constitute about 78% of the cases, or can happen in the body and tail, which is 20-25%. Surgery is the main line of treatment and the cornerstone of treatment. In 1960, postoperative morbidity rate was about 60% and mortality was 25%. Nowadays, mortality is only 2% and morbidity 30 to 40%, which is in high volume center. So this is important for all junior doctors, because I saw many cases which is resectable pancreatic or periambulatory tumors, and faculty staff telling them that the mortality is high, it's better to live with your kids and your children, just do metallic stent and go on. No need for Whipple because it carry high mortality. So if you don't do it, or if you don't know how to do it, just send it to the people who know. Types of resection is Whipple pancreaticoduodenectomy, distal pancreatectomy, segmental pancreatectomy, or total pancreatectomy. Here we see how to assess resectability. So this is the mass in the head of the pancreas. This is the IVC. This is the left renal vein. This is the aorta. This is a spermomesenteric vein, and this is a spermomesenteric artery. So this mass is away from the spermomesenteric vein. There is a fat plane here. You can see it, and there is no encasement of the vein at all, so this mass is resectable. This patient is candidate for surgical resection definitely. Another case is what we call borderline resectable. Borderline resectable, so it means that there is an encasement of the vein or the artery more than 180. So if the vein more than 180, or there is encasement of the artery even less than 180 degrees. Contraindication for resection is distant metastasis, either in the liver or outside the liver, peritoneal nodules, or locally advanced with arterial invasion, either SMA or the celiac trunk. In Whipple procedure, we remove the head of the pancreas, whole of the duodenum, lower end of the bile duct, and with or without gastric antrum. And this is a picture of the Whipple specimen after removal. And this is the picture, the real picture of it. The steps of the Whipple, I know that many of you know about it, but we'll say the steps rapidly, and we'll go about the tips and tricks after that. The first step is the Cocker maneuver, where you mobilize the duodenum until you see the left renal vein or the aorta. Then you open the lesser stack and go for identify spermomesenteric portal vein confluence by removing or dissecting it from the posterior surface of the neck of the pancreas to be sure that there is no anterior invasion. Actually, anterior invasion is very rare, but you have to do it first. Then the third step, cholecystectomy and dissection of the CBD and cutting it, then portal vein dissection and cutting the gastroduodenal artery, then DG mobilization, after that cutting the stomach, pancreatic transection, and reconstruction. Reconstruction, so you need to reconstruct the distal part of the pancreas, you need to reconstruct the stomach by gastrostomy, and then reconstruct the common bile duct. So in the stomach you do gastrostomy, in the pancreas and the bile duct you do hepaticostomy, but in the pancreas there is always debate between pancreaticostomy or pancreaticogastrostomy. So this is a picture of resection. Here we see this is a remnant part of the pancreas. This is the pancreatic duct, which is small, and this is the spermomesenteric vein. This is a splenic vein, and this is a portal vein. And this is the reconstruction after that, pancreaticogastrostomy and hepatico. This is pancreatic gastrostomy, and this is the hepatico-nephrostomy. So the debate between pancreatic nephrostomy versus pancreaticogastrostomy. So for my technique, I usually do pancreatic vaginostomy, double layer pancreatic vaginostomy without stenting. But it's better to do what you actually mastering. So I don't recommend you to change the techniques between different techniques of pancreatic vaginostomy or pancreatic gastrostomy. You just do whatever you know and whatever you are mastering. So theoretically, pancreatic gastrostomy is better than pancreatic vaginostomy because of the rich gastric blood supply, and the pancreatic enzymes usually are not activated in the stomach. So the theory of the cause of the leak is the pancreatic enzymes which digest the anastomosis is prohibited. But meta-analysis by 3 randomized controlled trials shows there is no added benefit of pancreatic gastrostomy than vaginostomy. That's why I'm saying that this is a theoretical issue, but pancreatic vaginostomy and pancreatic gastrostomy, there is no difference in results if you are mastering any of them. Artery first approach is another trick you need to know if you are doing pancreatic surgery. So the artery first approach, you need to be sure that the spermomesenteric artery is away and not invaded by the tumor. And this is happen early in ulcerate process tumor. So in ulcerate process tumor, if there is no clear evidence that the tumor is away from the spermomesenteric artery by radiological criteria on the CT scan, you need to do first the artery approach. After you go through the lesser sac and you dissect the spermomesenteric vein portal vein confluence, you retract it, and you need to do an early dissection of the head and onset of process from the spermomesenteric artery. If you find that the spermomesenteric artery is not invaded at that time, you can continue for Whipple, and if the artery is invaded, you can go for triple bypass. And the second indication is borderline pancreatic tumors after neoadjuvant. Also, there is no clear evidence of no invasion of the artery. Portal vein reconstruction and spermomesenteric vein reconstruction. So the NCCN guidelines put the portal and spermomesenteric vein invasion as a borderline pancreatic tumor, and this is candidate for neoadjuvant chemotherapy. And usually this is what we do if there is a big segment of the portal vein is invaded. But if there is small portion of the portal vein with encasement more than 180, you can go for surgery and reconstruction, primary reconstruction. Sometimes you don't need to put a graft in it, and which is not a big deal. And meta-analysis shows there is no different in morbidity and mortality after doing portal vein and spermomesenteric vein reconstruction in good hands and high volume centers. So most of cases with portal vein and spermomesenteric vein reconstruction is done because you discover that there is lateral invasion of the portal vein or the spermomesenteric vein, which is not shown on the CT scan, or there is encasement more than 180, but for short segments, not for long segments. And this is a case with real spermomesenteric vein invasion, and this was partial, so we did partial reconstruction of the spermomesenteric vein. We see the clamp, the upper clamp is on the portal vein, and the lower clamp is on the spermomesenteric vein. And after that, we resected part of the vein and reconstructed. And you see during mobilization, after mobilization of the spermomesenteric vein portal confluence, you have a good length, so you can even totally resect part of it up to 2 centimeters and reconstruct it back again. Arterial reconstruction carry very high morbidity and poor short-term and long-term survival, so there is no data sufficient to do arterial reconstruction. For distal pancreatectomy, you do it for tumors arising in the body or tail of the pancreas, and there are 2 types. Classic left to right distal pancreatectomy or radical antegrade modular pancreaticosplenectomy or RAMPS. The left to right distal pancreatectomy, in this case you do perform early ligation of the splenic artery followed by mobilization of the spleen and the pancreas from the left to the right. Disadvantages: there is inadequate nodal dissection and high rate of margin positivity. The RAMS is my preferred technique. Usually there is complete regional lymph node dissection unless instance of margin positivity. You go from medial to lateral, you dissect the splenic portal vein confluence from the neck of the pancreas, and then you cut the neck of the pancreas, and then you mobilize the gland from medial to lateral. And at that time, if there is a posterior invasion, like in the gluten fascia or posterior peritoneum, you can take it safely and do adequate lymph node dissection. In this pancreatectomy, sometimes you need to do more aggressive resection. So in this case, the mass of the pancreas is attached to the stomach, so I had to do partial gastrectomy with it. This is a case of total pancreatectomy, which is done for pulmonary tumor, but the pancreas has a lot of cysts. It was a polycystic pancreas, so there is no way to reconstruct it. So I had to do total pancreatectomy and splenectomy. Thank you.